our fifth edition of the Greater Petaling City-wide Capacity Strengthening of the Multidisciplinary Team Management in Breast Cancer. My name is Dr. Teoh Ying, and I'm one of the breast oncoplastic surgeons from University Malaya Medical Center. So we are glad to have actually our guest of honor, but I think probably some of you have heard the short discussion earlier. Professor Dr. Palak Popat will join us shortly after this. So this meeting is held actually in support of the Global Breast Cancer Initiative Implementation Framework by the WHO. And this emphasizes on 3 pillars of achieving early detection and management of breast cancer. So what are the 3 pillars? So we talk about health promotion for early detection in the pre-diagnostic interval, as well as the timely breast diagnostics during the diagnostic interval, and the comprehensive breast cancer management. So here we are today at the 3rd pillar, mentioning about comprehensive breast cancer management. So for the past few episodes, we actually engaged a few hospitals who are mainly the spokes hospital around in Greater Petaling. So before that, we have Hospital Shah Alam, Hospital Sungai Buloh, Hospital Serdang, as well as Hospital Putrajaya together with us. Okay, so for this round, we will have Hospital Tengku Ampuan Rahimah, which is formerly known as Klang Hospital. So what we plan to do is that normally this meeting will be led by the spoke hospital from the public sector, with the presence of the experts from its hub hospital, So what is special about this edition is that we do have expert panelists from the private sector as well, giving in their opinions about the case that we're going to discuss tonight. All right, so let's kickstart our program with the introduction of our main leader of this project. So she is none other than Professor Dr. Noor Aisha binti Muhammad Taib. She's currently the director of the Cancer Research Institute, as well as our consultant breast surgeon in UMMC. She is the lead person in this project since 2019, and she's also the main principal investigator in the Rebung project, which is a reducing barriers in cancer early diagnosis in urban B40. A special interest including quality improvement projects, as well as genetic screening subjects. So over to you, Prof. Aisha, for the introduction of this program.
Hello, thank you very much, Dr. Teoh, and good evening, everybody. Assalamualaikum warahmatullahi wabarakatuh. I think all of us are here to really try to see how we can improve our networks within the Greater Petaling City, which is really the Greater Klang Valley. We know that multidisciplinary meetings as well as team management will improve outcomes for our breast cancer patients. So this project is a spin-off from one of the first action plans of the Greater Petaling City Cancer Challenge programs that was funded by the Islamic Development Bank and International Atomic Energy Agency in 2019. So in this year, we have actually started to do our own demonstration MDTs across the city with 6 hub and 6 spoke hospitals. So our first event that we had was in December last year, where we had Professor Ben Anderson, our WHO medical officer, who spoke to us about the WHO breast cancer initiative, where we have the 60-60-80 targets by 2035. Therefore, which is 60 days diagnostic interval for breast cancer, 60% presenting with stage 1 and 2, and 80% of patients having completed all their treatments. So today is a focus on radiology. So that's why we have a very eminent professor from Tata Memorial Hospital to share with us their experiences so that we can also learn where we have when there is a resource constraint, how we can improve and excel in what we do. So we have had about 5 installations, where the first one we received about 151 participants, And that was where Professor Ben Anderson presented the WHO breast cancer initiative. And we had the second one was really concentrating on pathology, where we had Professor Dr. Jane Brock from the Harvard University in the US in February this year. And we also had on palliative care with our own Dr. Sylvia McCarthy from Hospice Malaysia presenting. And of course, we had one in May where we had Professor Dr. Rima, a radiation oncologist, who gave us a very nice talk. And we had a very good discussion with all the hub and spoke hospitals. So as we know, we have actually produced from this project one output where it is a document of how we can implement MDT across the city. And this document is available. We will provide you the link if you're interested in the chat box later. This is the best practice document for people who are keen to actually start MDTs in your hospital. The issue in Greater Petaling is that most of us who treat breast cancer may not actually have the whole team members within our hospital. So we are trying to see how we can network across the city with people and hospitals with the complete set of multidisciplinary team members. So with that, this project is not going to end this year. This project will continue next year with implementation of intra and inter-hospital MDTs. And we hope that all of you from all the hospitals across the city will be interested to be part of that implementation. So with that, thank you, Dr. Teoh. I will pass back to you the floor. Thank you.
Thank you very much, Prof. Okay, I think we have to tweak the program slightly as Professor Popat has yet to join us for this meeting. So we will commence on the discussion of the case, all right? And as an introduction, we have 3 speakers today with us today, and also 4 panelists coming from both the private as well as the public sectors. So in no particular order, I would like to introduce our speakers for today. So first we have Miss Hani Atiqah Saim, currently a general surgeon at Hospital Tengku Ampuan Rahimah Klang, HTAR Klang. And she has graduated from her master's from HUKM in 2022. And she has currently been attached to the same hospital for 1 year plus. Next up, we have Dr. Maninder Pearl Kaur, or formerly known as Dr. Mindy. She's our consultant radiologist, and she has obtained her fellowship in women's imaging from France, Italy, as well as Malaysia. Currently, she is the consultant breast imaging radiologist, as well as the head of breast imaging unit at the Department of Radiology in Kuala Lumpur Hospital. She's also a visiting specialist at HTAR Klang. Her special interest in breast imaging, including all the intervention as well as the imaging specs of the breast. And she has special interest in the contrast enhanced mammography. And she also contributed to 2 books, all right, 2 radiological books so far. Next up, we have Dr. Sukanya Banerjee Nair, who is our anatomic pathologist, currently also with HTAR Klang. And she is a graduate of Monash University and was a house officer from Penang Hospital. She qualified with a doctor in pathology from UKM, as well as FRC Path from the UK. And her main training centers were Hospital Kuala Lumpur and University Kebangsaan Malaysia. As for the list of panelists in no particular order, we have four of them here. So first, I would like to introduce Ms. Suraya Baharudin, who is our consultant breast oncoplastic and reconstructive breast and endocrine surgeon, currently practicing in the Gleneagles Hospital since June 2020. Prior to that, she has 21 years of experience working in the MOH, and she has worked in various hospitals around in Malaysia. She has obtained her fellowship of the breast and endocrine surgery from the local, as well as from Thailand and also from Japan. Next, we have Dr. Vijayalakshmi Krishnapillai, which we also call her fondly as Dr. VG. She is currently the senior consultant radiologist practicing in Gleneagles Hospital KL, and she has obtained her fellowship in breast imaging from the MOH Malaysia, as well as from National University Hospital in Singapore. And her main job description is mainly in breast imaging. Next up, we have Dr. Lee Bang Rom, who is a graduate from the University of Malaya in 1999, and he holds a Master in Pathology from UKM in the year 2007. He also pursued his study in a Diploma of Dermatology, and his special interest in dermapathology has brought him to Japan in 2012 to further his study in dermopathology fellowship training. Right. Currently, he is he has a very long CV here, but currently he's also our main consultant pathologist attached to Gleneagles Hospital Kuala Lumpur. Apologies if there's any error in the introduction, Dr. Lee. Right. Last but not least is Dr. Azura Deniel, who is our clinical oncologist from KPJ Ampang Putri, and she has obtained her undergrad degree from the University of Wales, UK in 1997, and she received her specialist master degree in clinical oncology from UM in 2007. So without further ado, can we have the slides being shared, sorry, for the discussion. May I hand over this discussion to Miss Hani? Thank you.
Thank you, Dr. Teoh, for the kind introduction. And thank you, Prof. Aisha and team for the opportunity to present tonight. So my name is Dr. Hani. I'm a general surgeon from HTAR Klang. And I'll be presenting this case tonight. So we have Madam S.A.H., a 25-year-old lady who was initially referred to us from Hospital Banting on the 14th of November last year. She presented with a right breast lump for a 1-year duration, increasing in size and causing discomfort. Other history, she had her menarche at the age of 11. She's married for 7 years, but nulliparous. She had history of breastfeeding for 2 months, no history of benign disease before. Her paternal grandmother had cancer, however, unsure what type. She had no history of taking OCPs or HRTs, and also she had history of ovarian cysts before. Other than that, she had no known family history of syndromes predisposing to breast cancer, no history of radiation exposure. She doesn't consume alcohol, and she's a non-smoker. On examination, there was a right breast mass measuring about 3 times 2.5 centimeters, firm, non-tender, and it was attached to the lower part of the right nipple. Couldn't pinch the skin overlying the lump. Her nipple was inverted. There was no nipple discharge, no podorange or ulceration. Her left breast was normal, and there were no enlarged axillary lymph nodes palpable bilaterally. No, she wasn't jaundiced, no hepatomegaly, and also her lungs were clear. So an ultrasound was done in Hospital Banting on the 10th of November, which showed a right periareolar solid lesion measuring 2.7 cm with enlarged right axillary lymph node 1 cm in size. For the left breast and axilla, it was normal, so the impression was a suspicious right periareolar solid lesion with axillary lymph node BRATS 4C. So these are the ultrasound images. Actually, this ultrasound was done in HTAR. Later, Dr. Mindy will explain the findings. Okay, so a true cut biopsy was done for the right breast lesion, which came back to be invasive carcinoma, ER/PR positive, and HER2 negative. So then we referred to radiology for a mammogram to look for intraparenchymal extension of the lesion. So I'd like to invite Dr. Mindy to present the radiological findings. Thank you.
Good evening, everyone. My name is Dr. Mindy, Dr. Maninder Pal, Dr. Mindy for short. I'm a radiologist attached to HCAL covering HTAR for breast imaging. So on the 15th of December 2022, we had a referral from the surgical department of a 25-year-old female who had a right periareolar invasive carcinoma. The reason for the referral was to look for infiltration of the underlying parenchyma. So ideally in this age group, an MRI would have been the recommended modality of imaging. However, due to significant artifacts with the breast MRI coil in HTAR, we performed a contrast-enhanced mammography for her. So on the contrast mammography, can I have the next slide, please? There are two images that we get. One is a low energy image, which is basically a standard mammogram. If you click enter, please, and to show the lesion. So there was a right periareolar thickening noted, and there was no obvious infiltration based on this mammogram because there was just extension at the retroareolar region, but no infiltration noted at this juncture. However, we didn't notice anything else. Next slide, please. A CT scan was done on the 22nd of December. Other than the breast findings, there was fatty liver changes, no distant metastasis was seen, and bilateral physiological ovarian cysts. Next slide, please. Back to you, Hani.
Okay, at this juncture, probably I will just open the floor to the panelists. Maybe have a few slides back. Hani, please. Thanks. All right. Maybe I would like to just pose the question to Dr. Mini herself and probably Dr. Vijay. I think there's a lot of participants here who are not very well-versed or exposed to the contrast enhanced mammogram. And you did mention that it would be the best, Hani, sorry, would you like to go back to a few slides before? Yeah, so what would be the benefit of offering CEM, and can CEM actually replace MRI in long term for centers who do not have MRI service so easily? Would you recommend to have CEM?
Yes, in KKM, CM has worked very well because we have very limited MR resources. So patients 40 and above, we usually do a CEM in such cases because we can do it immediately on the same day that it is referred to us. We can do the second look ultrasound and biopsy on the same day. So we are able to do functional imaging immediately. To get an MRI in the MOH setting is rather difficult because we don't get that many MRI slots for breast imaging in HKL at least. But in Klang, the coil has been spoiled since 2019. We've been waiting for a replacement machine, and it's been a long time since we've been waiting for that. So it worked very well for Klang because we are able to stage the breast for all these patients.
All right. All right. Thanks, Mini. Yes, sorry.
No, I would like to add that,
Vijay.
Hi. On ultrasound, we see this little cystic lesion. Maybe if you look at it closely, there is some echogenic component within, which could be inspected debris or it could be a papillary lesion. But sonographically, I would have put it as indeterminate, maybe by registry and a follow-up in 3 months. Because to me, it doesn't look suspicious, good enough to be called suspicious because of the sonographic features. Of course, a papillary lesion can be a papillary carcinoma, but sometimes it may take time. So usually I'm not that gung-ho that, you have to biopsy every small lesion that you see, because sometimes we see many small lesions like that. So in this way, the contrast enhanced was very good because of the contrast enhanced, it enhanced, and we were able to pick it up and biopsy. So I think the benefit was there for this case. So I think it was a good thing that, they did the contrast enhanced, but unfortunately, not all of us have contrast enhanced CT.
Yeah, definitely.
So I think the contrast
enhanced
memo. Yeah, sorry.
Yeah. I think it will benefit quite a lot of centers when we have a CEM.
Yeah.
Yeah, right. So back to Hani, I think you have a question to ask the panelist.
Yep. So the first question would be, would upfront surgery or neoadjuvant chemotherapy be best for this patient?
So I open the floor, probably Miss Suraya or Dr. Azura, if you're around. So what would your preference be? I mean, based on what Miss Hani has already presented earlier.
Hi, Assalamualaikum everybody. I think this patient has got a 2.7 centimeter tumor, but the lymph node is suspected to be involved. So she would have a CT2 and 1M0, but the ER/PR is positive and HER2 is negative. So I think in terms of decision to give neoadjuvant chemo, we usually concentrate more in terms of trying to achieve pathological complete response, PCR, which is higher in triple negative and also HER2 positive disease. So I think ER positive, HER2 negative, the expected pathological complete response rates are actually lower. So this would be a case of discussion between the oncologist and the surgeon to see which would be the better option. I think some surgeons prefer chemotherapy, neoadjuvant chemotherapy, if they think that it will help to improve the surgery that will be done, or if they are convinced that the lymph node is positive. Maybe it can be discussed. Yeah.
Yeah, what's your take then, Miss Suraya? Would you go for upfront surgery at this point of time, 3 centimeter, or would you send to Dr. Azura for a cycle of chemo first?
Okay, so basically in this case, it depends on the volume of the breast also. I mean, looking at I've seen the slides. So if the breast is big, 2-3 centimeter is not a problem for people like me, Oncoplastic, to do the surgery upfront. But it's just a matter of whether your lymph node is really positive or not. So it's either, it's in overseas, it's very important for them to determine. Either you do a ultrasound guided biopsy of the lymph node, or maybe you do PET scan to confirm if it's really positive. So like for us in private, we do PET scan. So I know in government is a totally different story. So if it's really positive, then with the skin involvement, I would rather go for chemotherapy upfront. But if let's say the lymph node was not really positive, then actually I think it is amenable to do surgery upfront.
Yeah.
And
So
as for the left, it's always hook wire because it's not palpable.
Yeah, we'll probably discuss about the histopathology at the end of this presentation. So I think there'll be a lot of questions, running in our mind, what to do with the left breast as well. So I think there's a question in the chat box to say that if the cancerous lesion is attached to the overlying skin or nipple, in this case, without enhancement of the skin in CT, can we say that there is infiltration of the skin? So I think particularly Dr. Lau would like to know whether this is a T4B or is actually a T2. Ms. Raya? Maybe Ms. Hani would like to clarify the staging.
So for the breast lesion, unfortunately, I wasn't there when the patient was examined, but in the documentation, the overlying skin was just attached to the tumor. However, there were no changes of the skin, no thickness, no poderunge or ulceration. So it's considered a T2.
Okay, so you're saying there's no clear cut of the skin changes, a typical orange or erythema or very stuck to that tumor, right, Sunny? Okay, maybe we just move on to the next question of yours first, and then we'll probably carry on with the case, and we can always come back and discuss. Over to you, Hani. Your next question.
So the next point of discussion would be if neoadjuvant chemotherapy was given for this patient, after that, what would be the best surgical option for her? Either a mastectomy or breast conserving surgery? Thank you.
Maybe
So I think
Dr. Azura.
Yeah, Ms. Pat brought up a very important question about BRCA. So she's very young, 25 years old. And I think we would actually try to do the BRCA testing early so that the surgeon can also plan whether she needs bilateral mastectomy or breast conserving surgery.
Yeah, I do agree with Dr. Azura. You know, if you have the facility, I think in HTAR they can send to HKL, isn't it? Or
Yes.
how do you go about in sending for BRCA testing in HTAR, Hani?
Yes, that's right. We can send the patients for testing to HKL. But this patient hasn't had any genetic testing done.
Okay. As for your question now, I think if you're planning for neoadjuvant, and of course if the tumor has shrunk, you can still do BCS. There's no issue.
So I think giving neoadjuvant chemo would actually give us some time to do the counseling and to do the BRCA testing and then plan the surgery. Whether then the decision can be made after the neoadjuvant chemo has been completed.
Yes. Another thing, if you plan for BCS, it's better to put a marker up front so that if the patient is a complete responder, then you can actually identify the lesion to do your BCS.
Yes,
I
okay.
would just like to ask, what is the PCR rate that we know of for luminal A or B type of breast cancer? Be it Dr. Azura or our pathologist can give some input on this.
I think luminal A, we don't expect a very high pathological complete response rate. So it can be as low as less than 20%, less than 20%. So, and because of that, the long-term outcome may not be as good.
Yeah. Okay, so it's just a discussion as well, and a lot of factors to consider in this patient. Example, the genetic or hereditary type of breast cancer. Okay, all right. Hani, over to you again. Just probably want to continue the case first. Thanks.
Okay. So for this lady, she underwent neoadjuvant chemo, FEC and taxane for 6 cycles, which was commenced on the 17th of January and then finished in May. Okay, which brings us to the next question. Would you reassess the lesions with imaging after commencement of the neoadjuvant chemotherapy? Thank you.
Maybe the breast surgeon and the radiologist.
Yeah, I think you definitely have to reassess the lesion because you know that it shrinks with time. Sometimes it may even disappear. So I think definitely you have to reassess lah. I'm sure all of us do that.
Some school of thoughts actually do not repeat the mammogram if there's a patient who has already planned upfront for mastectomy, even after a neoadjuvant. So do you still advocate doing
No,
a
if-
mammogram and the
no.
ultrasound?
No, if you are planning mastectomy, then it's not going to do any difference because you don't want to radiate her. But I think ultrasound will not be harmless lah in doing an ultrasound scan.
Okay. Ms. Suraya, do you frequently repeat all your patients post-neoadjuvant, both mammogram and ultrasound?
It depends on what you said. If my plan was initially and towards the end, because sometimes patients do change, up front they wanted mastectomy and suddenly they change to BCS, or BCS then they say buang lah, they want to remove. So at the end of the day, the final consensus, if they wanted to do BCS, of course I would want a pre-op imaging. But if they decided for mastectomy plus minus reconstruction, usually I do repeat also.
Okay. All right. Does this answer your question, Ms. Hani?
Yes, thank you. Yes, it does.
All right.
Okay. I'd like to pass back the mic to Dr. Mindy. She'll present the CEM findings post-chemo, followed by the hook wire localization of the left breast lesion. Thank you.
Thank you, Hani. So this patient came back to us somewhere after 2 cycles of a chemotherapy for a reassessment ultrasound of the left breast lesion sometime around February 2023. Unfortunately, we could not see the left breast lesion on that ultrasound. So the chemo, they continued the chemo and she was referred back to us post-chemotherapy to see if we could still find any enhancement in the left breast. So we performed a contrast enhanced mammography again in June 2023. Can we go to the next slide, please? The right breast lesion was that was previously seen was not seen in the current current contrast enhanced mammography. However, there was a tiny focus of asymmetric enhancement only seen on the MLO view, which was not seen on the CC view. So this had become a challenge for us because now we have a lesion that's not visualized sonographically, only seen on one view on the contrasted mammogram. And go to the next slide, please. Can we have the next slide, please? So the right side, just to show you the previous image in December and in June, showing a resolution of the lesion. And the next slide, please. So this was the lesion that was visualized on the low energy image previously, but we don't even see anything on the low energy image on the current scans. So it was a very challenging task. I had to discuss this case with the surgeons, and we had a tough time deciding how to approach for the hook wire localization. So we attempted to perform an ultrasound to look for any lesion at that region. Again, a very close second look ultrasound. Can we go down to the next slide? So we found something at the 3 o'clock position. We thought, okay, maybe this is the residual lesion that we see on the mem. We attempted to biopsy this lesion. I mean, not biopsy. So I attempted to put in a hook wire in. However, to the subs, please. Next slide, please, Hani. Is the slide stuck for you all as well?
Yes, I think it's moving. Yeah, it's moving now.
Okay, so this is like previously on the toe. Okay, so if you look at this slide, the anterior lesion that we had done on using ultrasound localization, obviously it was very far from the lesion that we had seen previously. So we concluded that this was definitely not the lesion that we had biopsied previously, and we had to find ways to region of interest for the surgeons. So what we did was we went to the Teoh images of this patient, and we looked at this. Ideally, her hook wire should have come in from the lateral aspect. However, because we wanted to mimic her previous previous tomosynthesis image to get ideolateral view, and we targeted the region exactly how it was on her previous tomo. So using the mediolateral approach, we inserted the wire. As you can see on the MLO, the wire is at the correct location. However, on the next slide, please. We were slightly short of the location on the CC view. So what we did was we measured it, and the next slide, please. So we measured, and we told the surgeon that when you see the hook, you have to go about 2.3 to 2.5 centimeters lateral to the tip of our hook, and that would be the region of interest, and to perform a wider local excision at that region. So this was the best that we could do. It was literally a blinded hook wire localization, but because we had DBT, we could try and locate the lesion using the thickness that the thickness that we saw in her previous DBT, and try to go towards the region of interest. So we managed to hook wire this, and next slide, please. Yes, so like I said, in this age group, usually in HKL, anyone less than 40, we would have performed an MRI because we tend to get a lot of background parenchymal enhancement. But to our surprise, in this particular case, we did not have much background parenchymal enhancement, so it worked out well for her. And anywhere else, and in my primary imaging center, we would actually have put the marker in upon the initial biopsy because we would want to see if the marker correlates with the area of enhancement on the contrasted. Thank you very much. Back to you, Hani.
Yeah, I think there's a few questions in the chat box mentioning the same thing about inserting tumor markers prior to the neoadjuvant chemo. I think clearly demonstrated by this case, probably the response was so good until the whole lump was a little bit difficult to identify. So what would be the dilemma in hospitals without breast surgeon then to refer for tumor marker insertion? Would that delay the treatment, or can the general radiologist help out by putting in the markers immediately?
I think generally the radiologists put in the markers. I think, I mean, in every center, it's a radiologist who put in the tumor markers, but it's a matter of whether they have it, in the hospital. Some hospitals do not have because of cost limitation, but whichever hospitals that have these tumor markers, it's inserted by the radiologist.
Yeah, I agree
But of
that.
course,
But
the request has to come from the breast surgeon.
yeah, I think it's sometimes the obstacles that we face, to refer to another hospital just for a tumor marker insertion. But I think whenever there's a need to actually do so, maybe the our hub hospital can probably help out our spoke hospital as well. Do you agree in that, Dr.
Yeah,
Mindy?
yeah.
Mm-hmm.
But
So
I
I
think
think, yes,
I
I think
Mr. Ryan.
yes, I
get-
think in the hospital where there's no breast surgeon, for example, last time I used to be a general surgeon myself in a district hospital like Kuantan and all those. It's all about communication with the radiologists and whether your radiologists are willing to work as a team, and if they are confident to put a marker, it's just a matter of getting the marker and buying it, maybe getting the kebajikan, or maybe some patient they're willing to pay. Actually, and if I'm not mistaken, Dr. Mindy did mention, in HTAR also, the patient needs to pay, right, Mindy?
Yes, after now we've suggested for the patients to pay to get the markers, but we are going to get markers through the surgical team. So yeah, markers were an issue in HTA. We did have markers before, but because all our patients were being referred out, the markers were not being used. So our markers actually expired. So each marker has cost a lot of money. So hence we did not purchase any markers. But if we had this case referred to us and we were told that this case was going to go for chemotherapy, we would have found a way, to maybe get a marker, somehow or another get a marker to be placed into the lesion in the left breast. I seriously feel that this patient should have had the marker before starting chemotherapy as well.
Okay, thank you. Over to you, Miss Hani. You want to continue?
Okay, so after that, the patient had a right central wide local excision with the Grisoti flap and axillary clearance with the left hook wire, wide local excision, and sentinel lymph node biopsy done on the 22nd of June. So here are just a few pictures, pre-op and post-op done by the visiting breast surgeon. And then on follow-up, her HPE came back to be, the right side was an invasive CA, margins clear, lymph nodes 2/15, ERPR positive, HER2 negative, and the left side was ill-defined dense fibrotic area with whitish solid cut surface. There was no tumor, no residual malignancy, and for the sentinel lymph node biopsy, it was 0/3. So I'd like to pass it to Dr. Sukanya, our pathologist, to present on the HPE findings. Thank you.
Good evening, everyone. Can you hear me?
Yes.
Yes.
So good evening, everyone. My name is Sukanya. I'm a pathologist from HTAR Klang. I understand I can talk about pathology all day, but it's 9 o'clock at night. It's not everyone's cup of tea, so I shall try to keep this concise. So basically, we received four specimens from this patient. 2 were pre-chemo, the right and left biopsies at the end of 2022. And then post-chemo, we received an intraoperative consultation for the left axillary sentinel lymph node biopsy, together with the bilateral breast wide local excisions and the right axillary clearance. Can we see the next slide, please? So the first specimen, upon the presentation with the right breast lump at the areola, we received an ultrasound-guided biopsy of the periareolar solid tumor. And here at the bottom of the slide, this is a low-power image of the core of the breast. At the bottom of the slide, you can see native duct of the breast. And this duct is of fairly normal caliber, lined by benign two-tiered luminal and myoepithelial cells with no cytological atypia. However, superior to the duct, we see an abnormal cellular population. And this abnormal cellular population looks like neoplastic cells arranged in large islands, as well as some smaller islands with intervening fibrodesmoplastic stroma. Within these islands, the central part is rather solid. However, if you see in this image, especially at the edge of this solid island, we can see cribriform spaces, which are really sharply defined, punched out, rigid secondary luminal spaces. And on the left of the core, you can see a smaller island where it really looks like a sieve-like pattern with these little regularly spaced secondary luminal spaces. And that's what we call cribriform arrangement. Because of the smoothness of the outline of these islands, we would still be concerned, could this be an intraductal proliferation rather than an invasive component? And so we would supplement this with immunohistochemistry. Next slide, please. On high power, we can see the tumor cells have fairly low nuclear grade with mild nuclear polymorphism, vesicular chromatin, inconspicuous nucleoli, and ample cytoplasm. Again, we see the rigid rounded spaces. In some areas, these clusters, they look a little bit more suspicious for invasion, a little bit more angulated, but it's very hard to say 100% without IHC, especially on a core biopsy. Next slide, please. We did the P63 immunohistochemistry, which highlights the nuclei of the myoepithelial cells. And on the right top corner, we can see a normal breast lobule where we see myoepithelial cells lining the outer edge of the ducts and the glands. Whilst in our tumor, in the center part, we see that there are no myoepithelial cells highlighted by P63 immunohistochemistry. With that, we concluded the right breast tumor is, in our biopsy, I should mention, we didn't see any skin or nipple tissue. It was just the tumor. So when we concluded this is invasive carcinoma, ER positive, both ER and PR positive in the vast majority of the nuclei, more than 90%, and the quick score was the highest, 8 out of 8. And the first digit is the intensity score, which is 3, the highest intensity. And HER2 was not overexpressed. We only saw weak incomplete membranous staining in a bit more than 10% of the tumor cells, and therefore that is negative. The tumor also was negative, the biopsy was also negative for lymphovascular permeation. So the next month, we received an ultrasound-guided left breast 3 to 4 o'clock biopsy, 3 centimeters from the nipple, from that enhancing lesion identified on CAM. Next slide, please. So here we see a different looking tumor, and we again see an abnormal cellular population in the breast, but it looks slightly different. So here we've got rounded islands of tumor cells, and they're very solid. We do not see any secondary luminal spaces. We don't see that sieve-like architecture. We don't see the rigid rounded spaces. We just see a big blob of tumor. And around the tumor cells, you can see that it's a little bit of a cleft with the native fibrous stroma of the breast. So wondering, is that artifactual clefting? Is that a ductal space? And we need to examine for myepithelial cells later. On the right side of this large rounded island, we can see a smaller cluster, a little bit irregular. So a bit suspicious, is that invasive or not? Next slide, please. So within the solid island of tumor cells, we can see that it's punctuated by these fibrovascular cores. As you can see, the sort of reddish areas where the vessels are, you can see the RBCs. So those punctuate throughout the tumor. But the tumor cells themselves are very low grade. They have mild nuclear polymorphism, vesicular chromatin, inconspicuous nucleoli, but a bit more ovoid than the right just now. These nuclei are a bit more ovoid, a bit more elongated, and a bit more amphiphilic cytoplasm. Next slide, please. So at the edge of this island, you can see a bit of a cleft, and maybe there is some myoepithelial cells. Maybe there are some myoepithelial cells rather flattened at the edge, a bit suspicious. We want to confirm with immunohistochemistry. Next slide, please. And this is another area where the cleft, and we're trying to scrutinize for myoepithelial cells. And I think I do see some flattened nuclei. I'd like to show you with the pointer, I just don't have it. So we would supplement this with immunohistochemistry. So based on the morphology right now, we see a solid introductal, we think it's introductal right now, a solid tumor punctuated by fibrovascular core with low nuclear grade. Next slide, please. And P63, in this case, compared to the right side, we can see that the P63 highlights the edge of the tumor cells. So we see the native ducts, the smaller ones. Next slide, please. Yeah, so surrounding the smaller native ducts, we can see the juicy myoepithelial cells, the round nuclei picking up P63, but surrounding just above it, we can see at the edge of the tumor, previous slide, yeah, just at the edge of the tumor, the myoepithelial cells are rather attenuated, squashed by all these neoplastic cells growing inside the duct. Also, if you maybe can notice just within that island, we can see the fibrovascular cores are also rimmed by myoepithelial cells, but the tumor cells within the ducts are negative for myoepithelial cells. And so this confirms our finding for a solid papillary carcinoma. And even the smaller irregular island is surrounded by myoepithelial cells. This is solid papillary carcinoma in situ in this biopsy. And SPCs commonly express neuroendocrine markers, so we also did those stains. Next slide, please. We did both synaptophysin, which was strong cytoplasmic granular expression, as well as chromogranin. Next slide, please. Very beautiful, diffuse, strong chromogranin expression, again supporting, which is very commonly found in solid papillary carcinoma in the biopsy. So with that, we concluded it is a papillary neoplasm favoring solid papillary carcinoma. Again, we did ERPR, very strong nuclear staining in the majority of the tumor cells, and HER2 was negative. In this case, we did a KI just to support the fact that this is a tumor of low proliferative index, but we also offered a comment saying that adjacent invasive components still cannot be excluded, and we should probably advise excision for definitive diagnosis. Of course, the decision is in the hands of better experts. Next slide, please. So this is just an overview. I will not go through this entire slide, don't worry. But this is basically the entire family of papillary lesions in the breast. And all I'd like to say is that basically papillary lesions are not best assessed on biopsy. They are best assessed on resected specimens. And so we usually give a bit more of a general interpretation, papillary neoplasm favoring whatever it is we are favoring. So it's either a papilloma with maybe DCIS or a papillary DCIS or an EPC or an SPC, with invasive papillary carcinoma being very, very rare. Next slide, please. So in this, just to highlight that actually solid papillary carcinomas can be completely in situ. I'll show you a picture later. They can also be in situ with areas of invasion, and this invasive component can be NSD, but also they can be mucinous. And we also can have a completely invasive solid papillary carcinoma. And so when we get a report of SPC and we are wondering whether we need to resect or we need to do chemo, and there is a confusion if the evidence so far is in situ and invasive, it's best to have a discussion with the pathologist if it's not reported. Yeah, so solid papillary carcinoma is characterized by circumscribed solid growth pattern, like our case just now. We intersperse delicate fibrovascular cores, low or intermediate nuclear grade. We cannot diagnose SPC in situ and call it in situ with a high nuclear grade. And usually they do express some neuroendocrine differentiation, but not always. And these tumors are ER positive and HER2 negative. If they are HER2 positive, it's also another indicator that this may not be an SPC. So this is another example of an SPC. This is an in situ disease. As we can see, really bald, rounded, circumscribed balls of tumor throughout the breast. And this is in situ disease. With or without myoepithelial cells, we would still call this in situ. This is a pattern for in situ SPC. This is another image from the WHO book. On the left side, you see an in situ SPC with that very solid ball of tumor, whilst on the right, you see infiltrative clusters of tumor cells arranged in fused glandular architecture. So it really does depend where the needle goes. If the needle goes in the blue area, we'll just see the in situ component. If we're fortunate to get it in the red area, we can offer you a diagnosis of invasive carcinoma in the background of an SPC as well. Next slide, please. So Just to conclude, well, just to summarize so far, the right side we have invasive breast CA, the periareolar tissue, and on the left side we have an SBC. In our biopsy in situ, but unable to exclude invasive component in the adjacent breast tissue. So 6 months later, we got the resection specimen together with a frozen section for the left axillary sentinel lymph node biopsy. Just go through the right first, because we will just go through the right because we've been presenting the right first. So this is the right-sided periareolar tumor, and the tumor is very interesting. On one side of the tumor, within the same contiguous tumor area, we have this cribriform pattern, just like what we saw in the biopsy. And here we can see this is definitely areolar dermal stroma, where we can see islands of smooth muscle right in the middle. These rounded islands, very pink areas, that's smooth muscle, typical for areolar skin. The rest of the breast skin does not have these smooth muscle bundles. So we see there's an abnormal cellular population. We've got islands of tumor cells arranged in these rather smooth islands of cribriform pattern, again with the secondary rounded punched out luminal spaces. Next slide, please. On higher power, again, like the biopsy, they have very low nuclear grade with hardly any mitotic activity, no necrosis, and again, very mild nuclear polymorphism. Within the same tumor, on the other side, again, you can see this is also areolar tissue, lots and lots of smooth muscle bundles within the intervening stroma. You've got irregular clusters, larger clusters, but they don't have the cribriform look that we saw in the other area. This is what I call an NST because it doesn't really fit any other type of special pattern, but basically they are irregular islands of tumor cells. Again, very low nuclear grade, hardly any mitosis. Next slide, please. And you just got these irregular stromal fronds sort of extending into the tumor islands. So this is the NST component. Again, P63 highlights the absence of myoepithelial cells. All of this, the cribriform as well as the NST, are invasive. Especially in cribriform, it's important to make sure it's not a DCIS component. So we did ER. Both components show strong diffuse nuclear staining. So ER is positive. PR is also positive, show very strong nuclear staining throughout the tumor, both in the cribriform and the NST area, whilst HER2 in my resection was negative. So because it's less than 10%, it's very negligible incomplete membranous weak staining. So the score is 0. Next, please. So within the two left wide local excision specimens with the hook wire, we didn't see any tumor. However, what we saw were intraductal cholesterol clefts with multinucleated giant cells, which you can see within these glandular spaces. Next slide, please. Surrounding these glands, sometimes we see some lymphohistiocytic infiltration. And within the glands, again, we see these cholesterol clefts. They are basically degenerative findings. Again, another nice aggregate of cholesterol clefts being engulfed by multinucleated giant cells, but again, no malignancy. So in summary, the right side, we have invasive CA of no special type with a cribriform component because it is a minor component. The tumor is 13 millimeters. The invasive tumor itself was 13 millimeters in size, grade 1, with no definite chemotherapy response, YPT1C, YPT and 1A. ER/PR both positive and HER2 negative. Whilst the right axillary lymph nodes, we found macromets in 2 out of 15 lymph nodes. In the left breast, both wide locals, no residual malignancy, while the left sentinel lymph nodes, we saw no malignancy in 3 lymph nodes. I think that's the end of my presentation.
Thanks, Dr. Sukanya, for a very extensive explanation. Maybe I just would like to ask Dr. Lee whether you have anything to add on to the description.
Thank you very much. Thanks for the invitations. And we pathologists are very impressed for the whole team, breast team, that stay back at 9 p.m. to discuss with these kids. Correct, right, Sukanya? I'm sure you're impressed by them, right? Okay. Thank you very much, Sukanya and the Gleneagles Pathology for the excellent diagnosis. I have no questions about that, the true cut biopsy. I'm supposed the true cut biopsy quality is absolutely very good. That makes the pathology diagnosis quite smooth and easy. Just questions to Dr. Sukanya. Do you routinely do Ki-67 on the true cut biopsy or not? Especially when I saw that on the solid papillary tumor, you did Ki. How about the other side, the right side? Do you routinely do Ki-67 or not? So that to help our oncologists or the breast surgeon to differentiate into luminal A and luminal B in this case. That's number one, right? Yeah, Dr. Suraya.
Oh, yeah. So on the left side, I think it was done because in this case, it is rare to get SPC in a young person. Solid papillae carcinoma is usually a postmenopausal tumor, 60s and 70s-year-old women. So I think it was to further supplement because it is a rare diagnosis in a rare age, and also to support the fact that morphologically it was low grade and of low proliferative index. So answer your question, on the right side, we don't routinely do KI 67 on all invasive CAs, but we do grade on biopsy. I grade on biopsies and we give a mitotic index, but with the ERPI and HER2, we don't give a KI yet, unless if it is required, and if it does direct management, then we would be happy to have a discussion about that.
Okay, thank you. Especially for the subsequent excisions, white local excision biopsy, I saw that some of the tumors have probably the higher grade. When I was younger, usually I go by my eyeball ruling and then based on the grading, based on very rigid on balloon and Richardson. But later I found that if you do a KI, actually it will help you support with the grade. For that on grading, I would rather put between 1 or 2. So, because some of the cells, for me, it look a bit pleomorphic. And with the presence of micrometastatic, which explain the behavior of the tumor, sometimes we have to believe the behavior of the tumor is important for the grading also. Then I would rather do a KI to make sure that it really reflects how they look like. Other than that, I think there are no questions about both of the diagnoses. I totally agree with both of the diagnoses. Thank you very much. Congratulations, Dr. Suraya.
Yeah, our pleasure to have you here as well.
Okay,
so I think we will have to. Yes, right. We will actually have to wrap up this session soon because we are giving way to our Professor Dr. Palak for her lecture later on. So probably, Hani, would you like to conclude the case?
Okay, thank you, Dr. Teoh. So this patient after op had she's currently undergoing radiotherapy to bilateral breast in IKN. And then I think I have one more slide after this. So here we just like to emphasize the timeliness of diagnosis, where Prof. Aisha mentioned just now that it should be 60 days from time of presentation to the treatment or intervention. So here's just a timeline of events for our patient. So on the 15th of November, she was referred to, on the 14th, she was referred. And then the next day, 15th November, she was seen in the Pink Ribbon Center here in HTAR. And a TrueCut biopsy of the right breast lesion was done on the same day. And then subsequently on 2nd December, she was seen with our visiting breast surgeon. And at the time after counseling, patient opted for BCS and decision was made for neoadjuvant chemotherapy, and a referral to oncology ICANN was made. And then subsequently CEM done, and then proceeded with biopsy of the left breast lesion. And then when reviewed on the 27th, HP findings was updated to Onco IKN, and then the first cycle of chemo was commenced by 17th of January. So which was about 60 days to the first cycle of the chemo, and then the op was done on the 22nd of June. So that's all from me. Thank you.
Thank you. And I would like to congratulate your team for excellent follow-up and the management of the patient as well. Thank you very much, Ms. Hani and the team. So I think we will need to wrap up this case discussion, but we will come back to this discussion if we have extra time. But now we would like to give way to our guest of honor today, who is none other than Professor Dr. Palak Popat, who comes from Tata Memorial Hospital, and she has been with the hospital since 2013. And she is a professor and consultant radiologist, focusing in breast imaging and interventions. And Professor Palak has a very extensive CVs mentioning about her extensive training in Korea, Beijing, Dubai, as well as Barcelona, and she has published multiple articles in very high impact journals, and she's also contributed many chapters in the textbook of radiology. So without further ado, I would like to hand over this session to Professor Palak. And today she will be giving a lecture on the standardized radiology reporting in breast cancer management. Over to you, Prof. Thank you.
Hello, evening, everyone, or rather a very good night to everyone. Before we start, that was an extremely kind introduction, Dr. Ying. Thank you so much. I would like to share my screen. Yeah, is the screen visible?
Yes, Prof.
Sure, all right. Thank you. So I was to cover a little bit on synoptic reporting and how we look at an overall perspective of breast imaging. Before I start, I would really like to congratulate on the wonderful case that has been discussed extensively. It was a beautiful case, and I love the way the localization was done for the contrast-enhanced lesion that was seen. Thanks, Dr. Kaur, for sharing that with us. So when we talk about the multiple modalities that we have in breast imaging, we talk of mammography, ultrasonography, contrast scan, MRI, and image-guided interventions. So in mammography, so for the ones who are not hardcore radiologists, you would come across words such as film screen mammography, which could be conventional, computed, or digital. We have two types of mammography, which can either be screening or a diagnostic setting. Like Malaysia may not have an all population covered screening program in place. India doesn't have one. The US has. So there are different policies and that run across places. So when the government usually pays for a program that is called as a screening mammography national program, and when a lady comes up citing that I have a symptom or I want to get a scan done. If I just want to get a scan done without any symptoms, it is called opportunistic screening, because I am choosing to get it done, or I have been referred because somebody thought I can get one. But if I have symptoms and I'm undergoing a mammography, it is called a diagnostic mammography. We have various aspects like the tomosynthesis image that you have just seen and the contrast enhanced mammography as well. Coming to ultrasound, again, we have a multi-parametric ultrasound appearance where we talk of a grayscale, the black and the white and the gray, the color Doppler showing vascularity, elastography showing whether it is hard or soft. ABUS is a promising tool, either in terms of under expertise or because of high volumes to be catered, the two areas where it might show some promising role. And contrast enhanced ultrasound is still not very common use, and it has its variable appearances. However, when there is an absolute contraindication to any contrast, perhaps it can be something which can be explored. An MRI has an added tool to a morphological evaluation by adding a functional evaluation, and which is by diffusion and the contrast dynamic kinetic imaging. A CT scan is not something is what you talk about when you talk of local imaging of the breast, and it is for a staging purpose and it is for a response assessment, and we don't see reasons for doing a lot many PET scans. We are comfortable doing a good chest, abdomen, and pelvic contrast enhanced CT for imaging. What I would like to take a second here and say, there are centers which may not have a contrast enhanced mammography. Not all patients will undergo an MRI, but there are enhancing lesions which may not always be seen on a mammogram, on an ultrasound, or you have diagnosed a lesion, you know it's a breast cancer, she's undergoing a staging scan. Always look at the breast very carefully on the CT scan, because additional satellite enhancing lesions or unexpected lesions can pop up on a CT, and when you're not doing especially a contrast mammo or an MRI, it is something which can be an outlier and can tell you, look at something more. So there are surprises which may be seen on a CT. So respect a CT scan, carefully seeing the breast area as well. Coming to interventions, under mammography, we have localizations as was done in the previous case. Stereotactic biopsies can be core or vacuum assisted, and specimen mammogram is something we need to do with a lot more attention, and I'll talk about it. Ultrasound, again, localizations and biopsies by core or vacuum, and MRI, again, localization and biopsies. We prefer vacuum biopsies are done. We do contrast enhanced mammo biopsies, but the beautiful case that was shown is when you do not have the aperture or the option of doing a contrast enhanced biopsy, then a combination of tomosynthesis and a wire localization is a beautiful combination. The whole idea in breast imaging as a radiologist is when you address something, you've identified something, you have to be able to offer a choice or a means of targeting it. That is a success of a clinical radiologist. Therapeutic interventions do come into place, which is vacuum-assisted excision biopsy, cryo, microwave ablation, high-frequency ultrasound ablation or HIFU, and radiofrequency ablation, which is not such a well-considered option. Interdisciplinary communication, as we just had a panel discussion running before me, is so important. And why is it important? Because I can give 2-page long report. Is a surgeon going to read it? No, because I, as a radiologist, I do not read my 2-page long report. So it is important to speak a language that the surgeon, the pathologist, or another radiologist is going to understand. And that is where synoptic reporting or standardization comes from. We do have various terminologies and different classifications, be it the American BI-RADS or the UK interpretation, where we can have a difference in the scoring systems as well. But what I am imagining, or the way I want to describe a lesion, has to exactly be understood by the surgeon in interpreting what am I trying to say. So after the 2-page long report, that one assessment is a language we all understand. And I always say that after that, the impression should be a letter to the surgeon. No matter what you've written, what your recommendation is of what to do next, or what are you going to do about what you have found in your report, must go in as a little note to the surgeon, which will make the whole difference. So this is the BI-RADS snapshots. They're all available everywhere. So in mammography, like, why is it important? If I'm going to say it is a scattered, of predominantly fatty, scattered, or a heterogeneously dense, or an extremely dense mammogram, am I trying to tell the surgeon something? Yes. And what I want to say is, if I have a BI-RADS 1 or a normal, extremely dense parenchyma, I would respect the surgeon for the palpable findings that the surgeon can pick up. I may miss, the best radiologist can miss a cancer sitting out here, all right? So we want to tell them, we would respect a triple assessment, please palpate, and if there is a hunch, if I have a normal fatty BI-RADS 1, my lexicon tells a surgeon they're confident. But if I have a normal BI-RADS 1 in an extremely dense breast here, but the surgeon palpates something, it would be nice for the surgeon to mark out the area that this is my concern, and the radiologist should very graciously accept that perhaps I may have missed something and it is time to do a dedicated spot compression or a tomosynthesis or an ultrasound if it has not been done before. All right, so that is about the parenchymal density. Talking about masses, so what do we see on mammo? Either masses or microcalcifications, and they can be described as either benign or suspicious. So like, for example, somebody might call this as a mass with interspersed lucencies, which is seen over here, or somebody may call it an island of parenchyma. In the end, what matters is, am I giving this a BI-RADS for a suspicious mass, or is this going to be a BI-RADS 1 because it's an island of parenchyma? Whenever we see something on a mammogram, it has to be combined with an ultrasound, which I'll describe later. Again, this is a small mass with a little internal lucency. Not all internal lucencies are going to be because of overlapping fat. You can have masses and overlapping fat, which projects as a lucency within, as seen over here, because this is within a well-defined isodense fibroadenoma. This is a benign appearing morphology, even on the mammogram. However, I would always want an ultrasound correlation. How about this? Even if I don't have an ultrasound, I know this is worrisome, and I can safely call this as a BI-RADS 4C. And if I have pleomorphic microcalcifications, I will upgrade it to a BI-RADS 5, whether I do an ultrasound or not. That is one part of my synoptic report. I am writing, getting this report done. However, an ultrasound still needs to be done to see if there were additional lesions which were suspicious or not. Again, like masses, we talk of calcifications, and we have specific lexicon for benign or the malignant type of microcalcifications. When I see these, I would call it BI-RADS 2, and this is benign. However, when I don't see these morphologies, then I need to characterize them better. So this is a skin lucent center skin calcification, BI-RADS 2. This is another one, a nice little calcifying cyst. This is BI-RADS 2. This is BI-RADS 2. So even if the surgeon, this is a popcorn, even if a surgeon sees, I'm not sure whether these microcals are benign, but if the radiologist on a detailed imaging has called them as BI-RADS 2, that tells a surgeon that this is comfortably to be followed up. These are benign vascular again, rod-shaped secretory calcifications. So how about this? For example, when I was talking, if the surgeon sees these, even as a radiologist, I would be worried about these, and I would say perhaps these are BI-RADS 4, but when I'm sitting at the console to report, I'm going to see them better. And we change the contrast, and I have the classical wedded light type of calcifications. I asked for an ML view, and they all beautifully laid out on the dead lateral view. This tells me that these are benign teacup calcifications. So when I see this, my synoptic report will say this is BI-RADS 2. I have done my bit of research to bracket them as benign, and the surgeon will understand my language. This is about the importance of follow-up, where benignity just stands out loud on follow-up. And these are the suspicious calcifications in two types, either the distribution or the morphology. So the distribution is important, where these may be benign, but these are more likely to be malignant. All right. So BI-RADS 1 is, we are all happy. There's nothing to worry about. BI-RADS 2 calcifications, we have the morphology and distribution, they go hand in hand. It's a combination of these two which will bracket them either as BI-RADS 2, 3, 4, or 5. So these are benign calcifications here. These are probably benign calcifications. We see them here. We see them here, scattered, round, monomorphic, punctate. We are not worried about these as much. Nonetheless, I would want a BI-RADS 3. If I have a contrast mammo, I might just run a contrast mammo, rule out nothing enhancing, and then still call them as a BI-RADS 3, because contrast mammo does not always detect malignancy showing enhancement in areas with microcalcifications. So keep your guard alive all the time. These are BI-RADS 4 types of calcifications, which are coarse heterogeneous, grouped, variable, pleomorphic, but that was benign, so it remains a BI-RADS 4. Segmental calcifications become suspicious because of their distribution, as I said, and these would also be BI-RADS 4. BI-RADS 5 would be the classical branching, linear, pleomorphic microcalcifications. I do not need any imaging to confirm. Just on a mammogram, I can call it as a BI-RADS 5, but we still always need at least an ultrasound to look at the correlation of the extent of disease and rule out disease in the other breast as well. So for example, this lady here, she had this microcalcification on a zoomed image, and it was very similar to her contralateral microcal. So you cannot leave it. What is a BI-RADS 4 is going to be a BI-RADS 4. And then the intervention comes in when you do a hook wire localization or a vacuum-assisted biopsy and prove either benign or malignant. And this one was benign. So synoptic reports, we follow the synoptic reports for all modalities. This is a snapshot of what we have for our mammogram. It is essentially based on the lexicon. And I would be happy to share these if anybody would want to. You could let the organizers know later. These are the reports in our hospital after a detailed discussion with the surgeons and the other breast radiologists. A contrast-enhanced mammography again. So for example, this is an obvious case. Yes, we are seeing the lesion on the contrast-enhanced imaging. This is another case where it was not very well seen, and probably an occult lesion with suspected breast cancer because of axillary nodes. There is some architectural distortion, better seen in retrospect, but we have this non-mass enhancement, and that was the index lesion. So again, contrast mammo, we have a very beautiful lexicon which is described, and it is available online as well. So our interpretation is based on the BI-RADS lexicon. Ultrasound, again, it has various features as I showed you before, the B, the color mode, and the elastography. And we talk of whether it is complementary or supplementary. So for example, coming back to the case which I described before, is this a BI-RADS 4 mass, or is it a BI-RADS 3 granulomatous mastitis, or is it just an island of parenchyma? The answer is an ultrasound and not anything else. This patient on ultrasound had very dense parenchyma and multiple areas of fat. So the convex borders are because of the nicely packed islands of fibroglandular parenchyma separating with the fat, and that gives the effect of a pseudo mass. So this patient had a palpable lump in the left breast upper outer quadrant. She needs to do nothing but just go home. She's a BI-RADS 1. All right, so that's the beauty of a supplementary or a complementary ultrasound. I would say it is complementary. This was the other lesion we described, and it is a beautiful benign appearing fibroadenoma on the ultrasound, and we can confidently ask this patient to come on a routine follow-up, and it does not need a biopsy. Similarly, this is a definitely suspicious lesion, and it appears so on the ultrasound as well. Ultrasound also, this is our synoptic report. The Byers lexicon beautifully describes the features in every imaging and its interpretation, and the positive predictive value of each feature, and the worst features are to be considered. ABUS, as I said, automated breast ultrasound, it shows lovely three-dimensional pictures. It's about time to get used to interpreting them the way we are used to interpreting CTs or MRIs, where we have a stack of images, and it takes time for the radiologist to understand. However, we need to remember eventually it's an automated picture. The moment we have a confusion, we need to hold the probe ourselves and have that little bit of imaging done by us. MRI is important. For example, this patient here, bilateral, both breast mammograms are available, some microcalcification seen over here, and the contralateral also had some indeterminate findings. That is the scan, and that's the other side as well. And that was a lobular carcinoma. The patient did undergo an MRI, and there are multiple other additional lesions seen. This was the index lesion, the microcalc, which I showed, and there are so many other foci seen in the contralateral breast as well, which were all completely occult on a mammogram. So if there is, so although lobular cancer does not feature expected lesions which are impalpable. So these are just the dynamic kinetic curves which show us the presence of the lesion and characterizing them. This is the synoptic report for the MRI. And LMP becomes important in a contrast-enhanced mammo and an MRI. The way we stratify our patients are, if it's a BRCA positive patient, she is not in who may or may not have a mass, she's come for screening. She should follow the protocol of a good time to screen during the menstrual phase, appropriate one, which is about 7th to 14th day. But if there is somebody who is dealing with a malignancy, we do not wait for the appropriate timing of the cycle to be able to capture her in the right phase, because you may have abnormal background parenchymal enhancement even in the non-favorable phase. And she needs to undergo therapy and biopsies and so much more. So we don't always wait for the right timing in an MRI. CT scan, as I said, it is for staging, and we need to see well, and we need to look at the breast also well. And we do have one checklist kind of a synoptic format, not to miss out on something that's important. Image-guided interventions, again, require localizations. For example, this lady over here, she had this mammogram and she had microcalcifications here, and there was another area that she was kind of concerned with. She wanted a breast conserving surgery. The initial disease appeared to be quite confined, but we had to look at the groups of microcalcs, and the worst looking one, which was furthermost away. So there were these multiple groups of microcalcs. So how do you decide which one? So take a magnified image, look at the worst morphology, look at the furthest morphology from the index lesion, and then this was targeted under hook wire localization, and the index lesion as well as the excision both were positive for malignancy, and she had to undergo a mastectomy despite having an apparently small lesion to begin with. Talking about stereotactic vacuum-assisted biopsies, when it comes to stereotactic or contrast or MRI, we do not prefer core, and we do prefer a vacuum biopsy, because you're just entering a pinpoint. The cost is too much. If you are going in, we might as well take more sampling. So they are always vacuum-assisted biopsies for us. So this is just how the sample is taken, and the cores are so much bigger and larger. Sometimes you can see the calcifications even with the naked eye. So that's the beauty of these cores. One last bit on when it comes to synoptic reporting on management, it is so important to tell the surgeon what you think you want to do. For example, this right breast mass malignancy, if I do look over here, I describe this mass and BIRATS 5. My job is done as a radiologist as per the medico-legal cell, yes, but no, because because you need to tell the surgeon how much to resect and if there is anything else. And I think the greatest challenge for a radiologist is not for diagnosing what it is here, but for ruling out that there is nothing else in the rest of the breast. And I think that is the most resource intensive as well. So for example, in this patient, there is this linear pleomorphic microcalcification. So you give the distance from the lesion to this point and of this microcalcification here to the nipple, and that precisely the surgeon with a blindfolded eye can be able to hear from your report what you are talking of and where is your extent of disease. So describe these lesions very well. This particular patient, she wanted to undergo a breast conserving surgery. Now there is an asymmetric density here. There were microcalcifications here, and it is a lower inner quadrant, and we are not sure of the kind of extent of resection because it becomes important. Upper outer extra resection is more easy compared to a lower inner with a so-called extended resection. So it is good to describe the extent very well. So what looked ghastly out here and that she needs a mastectomy was the first opinion, but you draw a horizontal line and precisely give the maximum extent on the outer aspect, and we also give the extent on the inner side. And when we interpolate this on the other view, again the lower aspect and the there was nothing above. If we see the microcals were on the other side and entirely in the inner side, they're all below the nipple. And when we draw a skin 3D topography, it is an absolutely breast conservable surgery. All right, so she does not need to undergo mastectomy. So what looks like a large extent involving 3 quadrants on an on a mammo actually may be a nice well-confined disease. So that communication with the surgeon is important. What you find and what is your extent, and there is nothing else elsewhere. So these are my pearls. We need to know the options of modalities of imaging in detail. History is important. Choose your modality wisely. Have a mental algorithm of what you want to do. Are you reporting something suspicious? Then how are you going to target it? Put it in your recommendation. Target always the most appropriate lesion, as I described. A good volume for sampling is to be preferred. Always discuss with the oncologic team and the pathologist and never stop exploring. Thank you so much.
Thank you very much, Prof, for your enlightening lecture. So we are actually at the end of our session, but before we let you go, Prof, I would just like to gather your opinion about the case earlier. Is there anything that you would like to comment if you had managed to join us during that session earlier? Prof. Palak, do you have any opinion about the case that we discussed much earlier, or did you just join us a little bit later? It's fine
No,
if you have joined us.
I did talk about it through my lecture. I mean, I love the papillary carcinoma that was detected on the left side and wire localized. So yes, we do contrast enhanced biopsies, and it was a very nice teaching message that if you see the finding only in one view, if it is not seen in the other view, how do you triangulate? Then the only bet that you have is either do a tomosynthesis guided localization or a biopsy. That's the clue, and that's the way to get around it. And it was beautifully done. And also to cite, so that lesion was also posterior. And when the imaging was done, it is very good to tell the surgeon, we always do that, exactly how away you are from your target is one point. And secondly, whenever we have a posterior based lesion, avoid going through the retromammary zone. Like it wasn't in this case, but just a general discussion. Wires in the retromammary zone, so a posterior axis, are full of fat. So the chance of slipping a wire are very high. So even when something has been placed well, try to go through a parenchyma so that you get better anchorage than traversing through the fat. It was a lovely case. Thank you so much.
Thank you very much, Prof. All right, I think this is probably the last installation of our MDT demonstration with the hubs and spokes. Maybe Prof. Aisha, do you want me to continue?
I just wanted to say hello to Prof. Palak. I think you actually hosted us in Tata Memorial, and some of us are here. I think Dr. Vaish and Miss Patricia, as well as Dr. VG. We were there, and we remember you discussed about how you use in the low resource setting on how you localize non-palpable lesions for the hook wire. So maybe, it's just out of curiosity. Maybe, our local people also want to know how you all do it in Tata Memorial. Because over here, I think most of us would use wires. So what is the usual practice in Tata Memorial? Just sorry, Laling, maybe 5 minutes.
Yeah, no, I would like to first of all say we have contrast enhanced biopsies and like contrast enhanced vacuum biopsies and MRI guided wire localizations. Everything that I'm talking of, we've changed our infrastructure in the last 4 years. All right. Until then, through our life, we have worked on wire localizations, all right? So that one wire can solve all your problems of breast imaging. That's the first thing. So never think that you don't have something, because that wire does wonders, first thing. So and there are two ways of our localization. If you're doing on a mammo, either we do it on a 2D or we do it in tomosynthesis. So again, tomosynthesis needs a software, but it is a software needed for biopsies. If the microcalcs are seen in two views, it is very simple. We do a 2D view, and so I did not have those images right now. I thought my topic was something else. Maybe next time I could just show it image by image. So we identify in one view, the shortest distance is chosen. The difficult axis is if it is lower and inner, or lower and central. So sometimes if it is inner, you go from the inner side. If it is outer, you go from the outer side. If it is upper, you go from the top. But what if it is lower central and much more closer to the skin? The machine has to go around 180 degrees. You sit down and you put the wire down from the top. All right. So it's a reverse CC view, and you enter from the bottom. So that's how the local. So that is the only technical challenge. That's how we do. For a tomosynthesis guided, we did not have softwares. So we identify the lesion seen. So the lady is compressed with the grid in place. And then the tomosynthesis is taken. And then we calculate the number of centimeters we need to enter in based on a scale which is provided next to tomosynthesis. Put in the wire and see the point where the lesion is seen the best, and the wire is seen touching that lesion in that particular point. And that's how we do a tomo-guided wire localization. All this is without any added softwares. We just need a little paddle. That's it. Specimen mammo, I just would like to say is, earlier we used to do one specimen mammogram, but over a period of time, we do two views. So we take the specimen, and there are clips, maybe a single clip and double clip, or the way it is. You hold if it is one clip on the outer side, you hold the one clip, let the specimen fall free, and take a projection and call it the CC view, and compare with the original CC view. Also, then you change the specimen, and let's say the double clips are here. I hold the double clip up, let the specimen fall, and then take a mammogram, and I will label it the MLO view. And I compare this with the MLO view. And in both the times, I have an anterior marker which tells me that this is where the skin is. So I have a complete orientation. So the specimen, which gets so buckled up, now opens up. It is tighter, and I can nicely compare the extent of microcalcifications, because our questions are, do I resect inferiorly? Do I resect superiorly? So there are many challenges that the surgeon faces. So we find this specimen imaging to be much more beneficial.
Thank you, Prof. Very nice talk. I think anybody else? Okay, before Ying takes photographs, sorry.
Maybe just a few last housekeeping messages. I think also from Prof. Aisha herself. Anyway, thank you very much, Prof. Palak. I really wish that we could actually import you here, occasionally you can just travel here and so. Okay, just a couple of final words to the participants. I think we are reaching the last installation of this demonstration of the hubs and spokes MDT, and we really hope that by next year we will be implementing this project among all the other hospitals around in Greater Petaling. So one of our master trainees will be actually helping us in this project. And we wish that any one of you who are interested in participating in this implementation project, you can contact our master tutor, even Prof. Aisha or myself. And the second note is about anyone who are actually interested in participating in this city-wide challenges. So we are actually recruiting not only breast surgeons, but anyone who is participating in breast cancer management. And if any one of you who are interested, we're actually having a brainstorming session coming up on the 14th and the 15th October. It's over the weekend. And if you are interested, I think Prof. Aisha has dropped the contact, the email of the Greater Planning Manager. So please feel free to join us. Okay. So, all right. I think thank you everyone for your precious evening or night. All right. And I'm sure everyone's tired. I'm also seeing my working clothes. All right, so before we end, probably we would like to take a quick photograph. Everyone, please switch on camera.
I would just like to thank for having me here. Thank you so much. Honored to be here. Thank you.
Thank you, Prof, for coming.